Welcome to The Question Is with Anthony Portantino. Should your health insurance cover the preservation of your fertility if you or a loved one faces cancer treatment, such as chemotherapy, that might render you infertile? Today we will hear the heartwarming and inspirational story of one woman's passion to have a baby and her political battle to extend fertility protection to both the men and women of California. That's right, we're going to talk about fertility, insurance coverage, and the miracle of birth on The Question Is. We will also discuss the current science behind fertility with the Director of Fertility Preservation at the Keck School of Medicine at USC. She will tell us how to make better patients and how to make babies. You thought you knew how. Let's ask the question. Welcome to The Question Is with Anthony Portantino. Today we're going to talk about fertility preservation. With me is Dr. Karine Chung, who is the Director of Fertility Preservation at the USC Keck School of Medicine, and Alice Crisci, who is the founder of Fertile Action. We are going to delve deep into the issue of fertility preservation, insurance coverage, and it is going to be a fantastic show this morning. With us, Alice. You started this all. You were 31 years old. 31 years old, and you walked into your doctor's office and you found out that you had cancer. What happened?
Well, I actually was on a trip for work to New York City. So I learned I had cancer in a 3-minute phone call.
Wow.
It was the shock of my life. It wasn't really for probably about 2 or 3 weeks, once I was in the throes of further diagnostic tests to learn what my treatment plan would be, that I discovered my fertility would be at risk.
Now, did the doctor inform you of that, or did you have to figure that out on your own?
I believe this particular doctor probably would have brought it up to me in a follow-up visit. I happened to be lying on a recovery table after receiving 3 biopsies to confirm my breast cancer diagnosis. And I looked up at her. I was in so much pain, and I just said, "Do I need to freeze my eggs?" and started crying immediately. And she said, "I think that would be a good idea."
And so you froze your eggs, and here we are 5 years later?
5.5 years later, yeah. So I froze. At that time, egg freezing was still considered experimental. It only had a 2 to 3% success rate. What I chose to do is split my egg supply and freeze half of my eggs with an anonymous sperm donor and half of my eggs unfertilized so that I could have choices in life. And today, yes, I am quite pregnant with my fertility preservation miracle baby, and was able to use my embryos this last January and heard his heartbeat for the 2nd time on my 5-year cancerversary. And
you have a photo to share with us today, too.
I do. This is a 4D photo of what my little man looks like. Wow. And I can't wait to meet him in person. And I'm told these images are very similar to what they actually look like when they come out.
Fantastic. So your personal story has a wonderful, wonderful happy ending. Dr. Chung, Alice talked a little bit about the advancements in fertility preservation just in the 5 years that she's been going through this. Tell us about how we went from embryos being the preferred choice to now eggs being much more usable and the statistics being better.
Sure. Well, so IVF itself has been around for a little over 30 years. And pretty much as soon as we started fertilizing eggs in the laboratory and doing in vitro successfully, it was relatively an easy transition to freezing embryos. Embryos are pretty sturdy, and the same techniques that we were using to freeze embryos was not working with eggs. So while the first baby from frozen eggs was born in 1986, which was only a couple of years after the first baby from frozen embryos, it took many, many years for us to perfect the science of freezing eggs. And it really wasn't until about the early 2000s that freezing eggs began to work. And we had to work really hard in the last 10 years to actually prove that it was working. As Alice mentioned, it had this experimental label for many years from the American Society for Reproductive Medicine, which is our governing body. that experimental label was just removed as of fall of last year, October 2012, and that was an extremely exciting day for fertility preservation, and it basically, to us, confirmed or acknowledged that all the hard work that we've been doing to perfect the science of freezing eggs actually paid off.
Now, obviously, there are different issues and implications whether we deal with an embryo or we deal with an egg, but there's also a cost differential too. It's more inexpensive to freeze an egg than it is an embryo, correct?
Correct. So the processes involved are similar as far as stimulating the ovaries to retrieve multiple eggs, but the actual cost of freezing eggs is less expensive than freezing embryos.
And the guys get away cheaper altogether, right?
Yes.
They do. So freezing sperm has been successful for decades, and that is currently still considered the standard care for fertility preservation for men who are undergoing chemotherapy or other treatments that might affect their fertility.
Absolutely. Alice, so you found out you had cancer. You're 31 years old. You're single. You never thought this was going to happen. You were an athlete. I heard you were quite a basketball player.
That was a little before turning 31. I was still. I like to refer to myself as a has-been, actually.
Yeah. Well, you were healthy in the prime.
Very healthy.
In the prime of your life.
Absolutely.
And all of a sudden, this traumatic experience happens. Obviously, with your Italian spirit, you're not going to let it get you down. What did you do next?
You know, I remember this time in my life incredibly vividly because I felt like I was at the top of my game, personally and professionally. Had a burgeoning company, had my whole future ahead of me, so it was the shock of my life, to say the least. But I also recall very vividly sitting in the business manager's office of the IVF clinic that was going to do my fertility preservation procedure and learning there was no organization that was willing to help me at the time with offsetting this cost. And even 5.5 years ago, the cost was exorbitant. Complete with the treatment plus the medications, I put $20,000 on an American Express card to make sure that he was possible.
Right.
I walked out of the office that day and turned to my friend who was with me, Jen, and I said, this must be why I got cancer. We're going to start a nonprofit. And that was a Wednesday. And whether it was the adrenaline of being diagnosed with something as, scary as cancer, or the Italian in me, the feistiness, that Saturday we put up our first website, kind of declaring to the world what we wanted to do with our organization. 3.5 weeks later, we had our first fundraising event, and then 4 days after that, I had a double mastectomy. I knew intuitively that we needed to start the momentum while people were kind of rallied around me and my story. And that way, no matter how sick I got, no matter what the future held with respect to my cancer treatment itself, other people around me could carry the torch should things slow down. And I'm so grateful that we took that approach because the organization has managed to grow despite the fact that I was in some form of cancer treatment for 3.5 years. And then, a year after that, really needed to spend in recovery. So by the time that 5-year mark hit where I heard his heartbeat for the first time, I was in a really great place physically, emotionally, mentally, to both be a mom and also to continue leading, the organization.
And the name of the organization is Fertile Action.
Fertile Action, yes.
And both of those words were chosen for a reason because obviously it's about fertility preservation, but it's also the action and the activism that you've brought to that issue.
Absolutely.
And so immediately you started raising funds. Now tell me, let's talk a little bit about insurance coverage.
Sure.
Because all consequences of cancer treatment are covered except which one?
Except fertility. So this act was devastating to me because I totaled 31 side effects that I endured from cancer treatment that were covered by insurance. Wigs are often covered.
Right. Reconstructive surgery.
Reconstructive surgery.
Laxatives.
Absolutely. You name it and it's covered. Special mouthwashes when your mouth breaks out in sores. So I was stunned that the thing that was most important to me, this risk of infertility, which is a preventable eventual diagnosis by doing fertility preservation, would not be covered. And what I learned in the process is that the way that insurance carriers were skirting this issue, or giving themselves an out, if you will, is they look at your benefits not under the cancer column, but they looked at it under, do you have infertility coverage or not? But we're not currently infertile.
Right.
And that was the thing that was so frustrating, is this will save the healthcare system more money now if you go ahead and prevent the infertility diagnosis than if you wait for me to be infertile and then either further deny me coverage because, you know, we're not in a state that mandates that all insurers carry infertility as a benefit.
Let's talk a little bit about that piece. The laws were written at a time before we had the advances in science that we do now. So they probably weren't thinking at the time that eggs would be so viable and so successful when they wrote all of the mandates. Would that be correct?
Yeah, well, I think so. I mean, considering how often cancer affects women who potentially don't have a partner yet, are not ready to start their family right at that moment, I think that the previous thought that the only option available was freezing embryos might have been something that a doctor wouldn't have brought up to a single woman, for example. But now that egg freezing is so viable and such a successful option, I think more and more women who might not be in the position to have a baby right at that point would still very much be interested in having the discussion and having the opportunity to freeze their eggs for the future.
Right, and what we found out, obviously in your case, you went out on your American Express card and covered the cost. There's a small segment of the population that can afford to do that.
Oh, absolutely. And through Fertile Action, we've established a network of fertility specialists like Dr. Chung, who essentially donate 50 to 75% of their fees to the patient so that it offsets that large cost. We should not be solving our problems in California by relying on community members to donate, you know, all their service fees. That's not the way that the system should work. Right. And, you know, despite the fact that, yes, sometimes embryo freezing can be a little bit controversial, it's a cultural question, because what do you do with the embryos, you know, when you discard them? That's where that concern of some physicians and speaking to people about it comes in. So egg freezing does open up this whole world. However, sperm freezing has been, you know, accessible for years and years and years, very proven, and that still wasn't covered by insurance.
Right.
And it's a very small fee comparatively. Right. Now the prices in general have gone down over the years because market demand increases, and of course, you know, prices go down. It's still cost prohibitive to the vast majority of people who are diagnosed with cancer, ages, you know, 15 to 45 even. Right. Because most people these days, you know, you don't have $5,000, $10,000, $15,000 lying around, you know, to cover something as important as fertility preservation.
And it's interesting, when you and I first started working on this issue 2 years ago, a woman contacted me on Facebook and said, my grandson has been on ice for over 10 years.
Wow.
Because her 17-year-old son came down with leukemia.
Oh my gosh.
And she was savvy enough to take him to a clinic and harvested his sperm, and they froze his sperm. He's still not married yet, but he's cured of his leukemia, and the mom's waiting for her to thaw out her grandchildren, and she was savvy enough to do that. And so,
well, and that's actually one of the sad things to me, Anthony, that you bring up, is that historically it's been the savvy people, the proactive ones, the self-advocates or the advocates for their loved one who think about this, because it hasn't been part of the medical infrastructure for cancer care. So 50% of oncologists still don't proactively have the dialogue with their patients. This handling legislation, making things a part of the infrastructure of cancer care will help with that, to ensure at least the conversation is happening more frequently. And what I also have learned in the process is that once the language changes where per diagnosis code, fertility preservation does become standard of care, that also will, you know, seek to affect change so that people are at least getting referred to the Dr. Chungs of the world, to a cryobank like California Cryobank, to ensure people have access at the right time.
Right, and obviously that's where we're going to go next in our next segment, is we're going to talk about the fight to get insurers to actually cover fertility preservation. Why is it in their best interest? Why it's in the patient's best interest? We're here on The Question Is with Anthony Portantino. We're talking about fertility preservation. When we come back, we're going to get right to the heart of the political movement that Alice Crisci started from her own personal story, and we're going to continue to talk about the science with Dr. Chung. Be back.
I'd like to take you somewhere where nobody else can go. Only the two of us know.
With Charter, TV will never be the same. Now you can make a date with your favorite movies and shows anywhere and anytime with on-the-go content from Charter.
We're back on The Question Is with Anthony Portantino. The current system, the current cards we're being dealt right now on fertility preservation as it relates to cancer treatment is horrible. Young women, young men suffer needlessly. The system isn't set up to help them. It isn't set up to improve their situation. Can you sort of talk us through some of the real stories out there?
Oh, absolutely. Anthony, I think part of the thing we have to keep in mind is that 30 years ago when oncologists were, treating young adults with cancer, nobody survived.
Right.
So the current legal system is based on medicine that never had a cure. And now in the young adult movement, you see 85% survival rates of these young adults and these adolescents, and the system has to catch up to where they are. But
right,
because
and 10% of all cancer patients in California are under 45.
Exactly.
So it is a large segment of the cancer
segment.
population.
Absolutely. And now we really need the system, the healthcare infrastructure to catch up to where we are. When we know anecdotally that when patients, in particular women, do not have access to fertility preservation services, they're choosing less effective forms of cancer treatment with devastating consequences. One woman in particular that I know personally went against her doctor's orders, did not receive tamoxifen, which is standard of care for a woman with hormone-sensitive breast cancer. She didn't start it right away because she wanted the year after chemo to try to get pregnant. And then she thought, I have time, I already had my mastectomy, I already had chemo, my husband and I will have a baby now, we'll try to have one child, and then I'll go on tamoxifen. Devastatingly, in that first year that she was supposed to be on tamoxifen, she had a cancer recurrence. She had to terminate the only pregnancy she will ever have the day before she then had to go in for a full hysterectomy.
Wow.
Now, clearly that is a heartbreaking story, but it's also a story of the financial consequence, not giving women access to these services. They did the exact same studies before they passed the mandate to ensure women could receive breast reconstructive surgery. They saw that women were choosing less effective forms of cancer treatment, not doing the mastectomies, opting for a lumpectomy even when it was recommended because they didn't want to be disfigured.
Right.
Now we see that once women have access to reconstructive surgery, they choose the appropriate form of treatment. We need to make sure the same thing happens now with fertility.
So you have a better patient in a sense who then gets cured quicker, who then can make the choices for their family as a cured, better patient. Would you?
Yeah, I definitely, I think that the story that Alice just described is just extremely relevant. I think that patients are always thinking about how their treatment is going to affect their fertility, and are there ways that they can ensure that they'll be able to have a baby later on. Infertility is a medical condition with lifelong consequences, depression, anxiety, and this is something that could potentially be preventable. So absolutely in the best interest of the patient, in the best interest of the insurers to cover this.
And that's the key. It's in the insurer's best interest to provide or update, we should call it an update, its standard of care to match current science. It's in their best interest to do that. Thus far, they've been reluctant to do that. I mean, you and I had a meeting 3 years ago. We brought all the insurers in the room and we said, we don't want to do legislation. You guys should just do this.
Exactly.
And they all said, well, think about it, we'll get back to you, and then never called back, if you remember.
Absolutely.
So then what did you do next? I mean, you obviously, you faced it head on. You, in a sense, became healthy again, stored your eggs, created your nonprofit. The next place for you to go was Sacramento and change the law. What did you do?
Well, the first bill that that you authored, thankfully, AB 428, we didn't get as far as we've gotten this year.
Right.
And it was
AB 912, right? Is
yeah.
the
Now our new bill is AB 912. And the climate's very different right now. So, you know, even a couple of years ago with Obamacare, there was so much uncertainty. Where are the costs going to be? Can we really contain these costs? Do we really understand, you know, what the financial impact to the state really is? And so we lost some momentum. You know, we were turned into a 2-year bill, and then we went bye-bye. And so bringing this back up with Assemblywoman Sharon Quirk-Silva this last year, it's been very interesting because it's a very different climate.
Right.
We know that Affordable Care Act is
It's
being implemented in October, no matter what.
Right.
It is on its way. Covered California is very real. And because of that, the rates have already been, you know, decided upon. So come October 1st, we do have better data now on what additional costs are to California. So we went through the assembly decently, and the CHBRP analysis,
The CHBRP analysis is an internal analysis of the bill and its costs and implications that all mandates have to go through in California.
Exactly, and the big difference between a couple years ago and now is that the cost used to be 3 cents per member per month.
Right.
Now we're down to 1 cent per member per month.
1 cent per member per month is the estimated cost of this. 1 cent, and we can have thousands of Californians be able to store their fertility, create viable children and families, and be better patients. 1 cent. Go on.
1 cent. And that's what we're really working on, even getting that lower, because some of the costs that are used in this analysis are a little bit outdated. And we did recently take an amendment that Senate Health recommended. We took an amendment that says, let's leave out anybody that's part of the Covered California Exchange program in October, since we still aren't really sure how this is going to go. This is groundbreaking historical legislation. You know, let's get a little bit of time under our belt. So the amendment we took is that let's only have this apply to large groups. We're okay with that for a couple reasons. As the co-sponsors of this bill, in addition with the American Society of Reproductive Medicine, Fertile Action looked at it and said, there are already large groups who have voluntarily added infertility coverage for their employees. So there's some evidence that they have been okay with the additional cost, and that this won't be cost prohibitive to their companies if they're the ones that have to absorb this. And the other thing that we looked at is, you know, sometimes, especially with insurance mandates in an uncertain time legislatively, you know, sometimes it's better to have 70% coverage than 0% coverage.
Right.
And because simultaneously we're also working to ensure that the Oncology Association adds fertility preservation into the language for standard of care for these individual diagnoses codes, I think that we're going to be able to really help 100% of people have access to this kind of care. And the big push, of course, is, well, let's start with shoring up this gap in the healthcare system to make sure that these patients, you know, are treated appropriately, that this is part of the cancer column. It prevents depression.
Right.
You know, it prevents the breakup of marriages. Culturally, there's certain cultures who, if you're not able to procreate, you're kind of shunned from your own society. You know, there's so many levels of implication. It will save lives.
Let's go back to the oncologist for a second. We know that some doctors, and it's understandable, they're focused solely on the cancer. They have a sick patient, they know what the cause of the sickness is, they want to cure that acute, serious situation, and they're focused.
Yeah.
Not all of them will talk about the implications of chemotherapy, for example. How do we change that culture, and what do we do as far as how do we influence the standard of care protocols? What's our steps to doing that?
Well, I think increasing awareness is definitely important, and the fact that oocyte cryopreservation is now considered a viable option will also help. But I think oncologists in general, they need to shift their way of thinking and bring it up even if they don't think that the patient is interested in it. I think a lot of the oncologists have assumed that, oh, this patient either, oh, she's going to be fine, she's not going to be infertile, or oh, this patient, she'll not be interested in fertility preservation, so I'm not going to bring it up. Part of it also may be that they have a limited amount of time with each patient, and of course the focus should be on treating the cancer and curing the cancer. But this is a quality of life issue, and fertility preservation is something that you can do to prevent something that will affect the patient lifelong, long after she's beaten her cancer. And so I think it should be something that is addressed in the same way. Cardiac or pulmonary side effects of chemotherapy would be discussed ahead of time, and if there were a way to prevent those complications, we would certainly recommend it. So I think fertility just needs to be emphasized more, and I think the more mainstream it becomes, the more people like Alice go and talk about their story and share their story, the more oncologists, I think, will change their way of thinking and emphasize it more.
Now at SC, at the medical school, obviously the fertility preservation program is one aspect of a large medical group.
Correct.
Do you interface with your colleagues in the other disciplines? I mean, you know, it's a teaching hospital, it's a medical school. Are we drilling down to medical students now as we're training the next generation of oncologists? Is that happening?
We are trying, mostly through research collaboration. And I think that when it comes down to it, when they have the patient in front of them, it's still focus on the cancer and the cancer treatment, and it's not always their first thought. But at USC, we're developing a group that's focusing on adults and young adults and adolescents, which is a group that has been much in need in terms of optimizing their treatment and their quality of life afterwards. And so there's a big push to increasing awareness about fertility preservation options to that population of patients. So I think it's getting there.
And Anthony, I do want to pick up on that point too with Dr. Chung. She is incredibly collaborative with the oncologist that's treating the patient, and having those types of relationships within the medical systems does help, because the oncologist feels more comfortable. What we're starting to see as well is a shift in their understanding that there is no evidence and there's no plausible science to suggest that a woman going through fertility preservation using medications to spike her hormones is not going to exacerbate her cancer, nor will it change her survival outcomes. And one of the greatest developments in the science has been how they stimulate women who have these estrogen-driven cancers, like endometrial cancer, like a lot of the breast cancers. And Dr. Chung can speak to what that is in particular. The greatest thing is that she has protocols now, along with her colleagues, that will prevent a woman's estrogen level from spiking beyond what it is in a normal natural cycle. And that has increased the confidence in an oncologist to make the referral and say, I'm okay with this. And even at Fertile Action, when we go through and approve applications, we always tell the patient, go ahead and seek insurance coverage wherever you are in the country, and ask your oncologist for a letter of medical necessity. That's a really key component of even fighting this insurance battle. The oncologist needs to say, yes, this is medically necessary because this patient is at risk for infertility from this treatment.
And that's another political piece or another battle that you're fighting. Not only are you taking this battle to California to change state law, but you're also going to be taking it to Washington because you want to change the medical necessity component for the whole country.
Absolutely.
So that's your next battle.
That's my next battle.
And in the middle you're gonna have a baby very soon.
Yes.
And so you are going to take a little time off.
Just a little.
A little time off, but I know you've already made your plans and your trip to Washington.
Yes, I have.
Because that is an important piece. I mean, the medical necessity. There's no question that if we can have a patient facing cancer store their fertility, preserve their fertility, they're going to be a happier, better patient. They're going to get cured faster. The insurer is going to save money. As you pointed out, the whole family will benefit. There's so many positives to this situation. I think you're going to be successful. I think you're working with, you have science behind you, you have passion behind you, and you're going to have a baby that's going to go from that electronic picture to sitting on your knee and be the poster child for why this is so important. So thank you for being here on The Question Is. I'm just pleased to have met you, to see you continue to fight this wonderful battle, and We'll be back on The Question Is with another topic next month. Thank you for being here.